Yes, I think we'll go on to this very interesting presentation from Dr. Senguttuvan and Dr. Venki. Yes, Dr. Senguttuvan, please start.
Hi, good evening. Thank you all for this opportunity. And thank you, Venki, for the kind words. So this we did recently. So we tried percutaneous USG-guided glue injection as a preemptive use in high-risk patient to avoid post-renal biopsy before the hemorrhage happened. So while doing, all of us do the renal biopsies, and one dreaded complication we're always afraid of is vessel injury and hemorrhage. So the incidence is close to 2 to 4%, and the bleeding is quite dramatic. So this will require transfusions and endovascular transcatheter embolizations. So all of us know about the complications related to the transfusion, the added cost for the catheters and coils used, and also the use of contrast for endovascular embolization in an already diseased kidney, or maybe in a single kidney as well. So this case, which we did, it's a 26-year-old male. He was referred for transplant renal biopsy for increasing creatinine levels. The clinical suspicion was the TMA, and it was quite refractory to plasmapheresis. He had pancytopenia with low platelet counts, and so biopsy was done with platelet cover as well. So this is the post-biopsy ultrasound image, what we see. So what I could observe was a persistent color flow along the biopsy track, and also a small pseudoaneurysm in the parietal wall between the in the intramuscular plane. So I waited for some time, but still it did not disappear. So considering the high risk of bleeding because of the platelet deficiency, so I did target the small pseudoaneurysm percutaneously using ultrasound guidance, and you can see I injected a glue into it. So once the glue injection was complete, the tract stopped showing any color flow. So we thought, okay, maybe we prevented, and followed up with serial ultrasounds and found that it did not produce any hematoma as such. So this is the post embolization track. This is the echogenic area, is the glue which we injected, and the shadow associated with it. So the another patient, again, you can see the linear track jet of color flow from the kidney parenchyma into the subcutaneous fat plane. And that echogenic, after injection, you see that echogenic focus, that is the glue, and we don't see any more flow in the biopsy track. So ideally, the best use for this technique would be for the native kidney biopsy. So we did try that also. Unfortunately, I don't have the images with me. So there, the target was always the anechoic area. The echogenic area was the area of hemorrhage that has clotted already. So this anechoic black areas is where there's active bleeding happening. So I aimed at injecting as close to the capsule as possible. And most of the times we'll need simultaneous split screen live images of black and white as well as black and white superimposed on color, B mode plus color. So that will help. One image, you can visualize the needle path and the anechoic area. The other image, you can visualize the color flow in that pseudoaneurysm like cavity. This was tried in the past, yes, glue and lipidol, an experimental study where an anticoagulated rabbit kidney was biopsied, and it was quite successful. And the other alternative would be to inject close to the capsule thrombin. 2 ml of thrombin mixed with calcium chloride has been injected, and it has found to be effective. The only thing is the cost difference. This glue is going to be around 800 to 1,000 rupees in cost. While that varies, the thrombin varies from 5,000 to 15,000. So a little details about glue. I am not sure whether you all use it or not, but we as intervention radiologists use it quite often. And this chemical composition is N-butyl 2-cyanocrylate. It is in a liquid form available in 0.5 and 1 ml oil. It's an adhesive. And in clinical scenarios, it is mainly used for skin wound care, for applying sutures. And we use in our brain AV malformations, AV fistulas, and also for portal vein embolizations. Sometimes we do liver biopsies, and the track could bleed, so we just embolize the track with glue. And gastroenterologists, medical gastroenterologists use it for endoscopic gastric varices embolization. So basically, it is a liquid of monomer The moment it comes in contact with ions, it polymerizes and becomes a solid. The polymerization is quite rapid. So we have to be very careful with that. Sometimes the needle could get stuck into the cavity. Of course, we can pull it out. It comes out with a gritty sensation, but yes, we can pull it out. And the only few fluids are allowed to come in contact that will prevent polymerization. That is water, distilled water. Normal saline should not be used. The other is 5 or 10% dextrose solutions and lipiodol. So it is ideally when you pick up glue, take a new syringe, take a new needle, dry while loading glue. And since, as I said, when it comes in contact with blood or any ion, it is going to solidify. It is better to avoid black flow of blood while putting the needle into the pseudoaneurysm. And the injection has to be quick. The needle has to be pulled out fast. And as I said before, if the glue sticks to the tip of the needle, we will feel the gritty sensation, but still you can pull it out. So apart from what we used here, and I guess for when we discussed about hemostasis at the tunneled line at the exit site, I think this should be useful. We apply over it, and this acts as a microbial shield as well. And the other situation where we have used glue was accessory vein embolization in fistulas. We apply pressure at the junction between the accessory vein and the parent fistula, and then we inject glue. This is usually done under fluoroscopy. And to add another point, glue is radiolucent, so you won't be able to see it in the fluoroscopy. So we mix it with lipiodol, which is radio opaque. It has two advantages. One, it makes glue visible, and the other advantage is that it retards the polymerization. So it gives us some leeway in adjusting the time of injecting and pulling it out. Thank you.
Thank you, Dr. Senguttuvan. I think there should be a lot of clarifications. Yeah.
Senguttuvan sir, I was wondering whether this glue technique can be used in aneurysms with which threaten to rupture.
Absolutely. We did one last week with amyloidosis. Bone marrow biopsy was done, and the blood, like the entire gluteal region, was hematomatous. So percutaneously, we guided into the aneurysm and injected glue there. Yes.
Sir, I was referring to the AV access aneurysm, sir. So
no, absolutely no.
Okay.
You will not see, it's a liquid. You will have absolutely no control over the way it is flowing.
Okay.
This is a little bit. This is going to block off. Then it can cause embolization into the pulmonary arteries. So no, not for this thing. That is why I said we'll be compressing on the fistula and the accessory vein junction and injecting.
Okay.
Can we use it in a pseudoaneurysm of an AV fistula?
No, sir. It has a very wide neck. So when you inject, it is going to fly off into the into the venous segment and also into the pulmonary circulation. Definitely not recommended.
Thrombin versus glue for pseudoaneurysm with the small neck.
Yeah, the neck matters. Again, there also thrombin would be better. Only thing is you have to compress the neck. You choose an angle. You should compress with the ultrasound probe.
What is the cost of this glue, you said?
Glue is around 800 to 1000 per vial. If each vial is 0.5 ml. Thrombin, Reliance has it at 5000. The other flow seal which they use for neuro things, 15,000.
So, I mean, the few occasions which you presented, they're all preemptive use, right? Not for.
Yes, sir. One native kidney. I didn't have the image with me. I mean, the moment we did the biopsy, it was like I can see a hematoma collecting rapidly, very fast. So I got a little scared. So why to unnecessarily put some pressure on the patient? I thought I will block up that anechoic area. I said very close to the capsule, I could see anechoic area, and I injected glue into it, close to the capsule.
Can I take it that even if you are not as precise as you in by locating the correct place, this is not going to cause any harm, right?
No,
if it is inside the kidney.
Yeah. So you aim it. If you can aim it into the pseudoaneurysm, it's fine. But even it can, if it is close to the neck somewhere, that will cause some pressure effect and inflammation that is going to occlude it. So basically, we are forming a capsule, a capsule over the kidney, new capsule.
What is the volume of glue we use?
I never 0.5 ml, never more than 0.5 ml. One single injection. Only thing is, if you try to aspirate to confirm that we are inside the aneurysm, you're going to block the needle. You have to take the needle out, and we have to take a new access it again.
So when you inject, what needle? You probably need a long needle, right?
Yeah,
like a long needle.
So these two patients which I had shown were transplant kidneys. So all I could manage was a short routine 24 gauge needle. I was able to manage. The native kidneys require your 22 gauge lumbar puncture needle.
22 gauge
lumbar puncture.
Now, Senguttuvan, this 24 gauge needle will in this gel will go through. Or
Yeah, it is liquid, essentially liquid, sir. It is like what to say? It is almost like saline only. Okay.
But if you use a long lumbar needle, if it's only 0.5 cc, won't it remain in the needle itself?
No, sir. The LP needle is quite narrow. It doesn't. 0.5 ml is adequate.
Okay.
When we do a biopsy, Bala,
yeah,
there have been some literature on use of desmopressin in high-risk patient of bleeding prior to doing kidney biopsy. So we need to discuss that point also. I mean, why end up doing all these things?
So this is Minerian.
Yes, Minerian,
yeah. I think I, as a practice, routinely do that before in a uremic patient.
Yeah. Not only uremic patient, there are other certain high-risk patients also where we presume, I mean, nobody can predict whether this patient will bleed or not. So why not use that as a
even today, a month for the tunnel bleeding, which my technicians are struggling, they are given Minerian already. And now I asked to, because I'm not able to go there. I asked them to use
you didn't try tranexamic acid?
Yeah, I mean, that was routinely given, no? The systemic, Minerian oral, and plus
no, the point is, I mean, will it work once the bleeding has occurred? That's the other point.
Which
Desmopressin is supposed to be given prophylactically, right? Yeah. So whether it will be helpful after the bleeding has occurred, I don't know.
So did I hear this correct? You all give Desmopressin before doing a kidney biopsy?
Yes, there is literature on that. You can give injectable, but since we don't have injectable, there are equipotent dose. I mean, how much injection is equal to how much of nasal spray is equal to how much of tablet. So you can choose any one of them. And Adrian, you are mentioning about cost of tranexamic acids. Over here, it doesn't cost much. 500 milligram vial cost, I think, about 70 rupees only. So 1 gram is 140 rupees. So we are okay with using tranexamic.
Right.
Yeah. What about the old-fashioned way of external pressure after biopsy? When we were doing biopsies earlier, we used to apply external pressure for about 20 minutes by the watch.
Transplant biopsy, I'm sure like that should help. Right? For a native kidney biopsy, I'm not really sure. I think that is where we are forced to do something or other preemptively sometimes, and I thought probably
even native kidney biopsy, if you see, I'll just tell you something. If you press the probe, you can see that there is a compression of the tissue inside. So if you are doing it with your gauze pad and then firm pressure with your palm, it does affect or it does prevent the bleeding. So immediately after biopsy, if you press for about 20 minutes, I think the bleeding incidence can be reduced significantly. We still do it. Whether it is right or wrong, I do not know, but we still do it.
Yeah. I think you should. We don't do 20 minutes. We do for 2 hours, and yet we have seen bleeding. And the reason is patients don't like to sit. They like to get up. They like to move about, and so that even though we try, it is a least expensive way of doing it.
Exactly. That's what I'm trying to tell you. Yes.
In our experience, I mean, in my experience, it's at 1 or 2 cases who will bleed, and you're in trouble.
Yeah, I mean, that brings this question is, when I was training, I was taught to do biopsy, pack it with 4 or 5 gauzes and put a elastoplaster tightly, hold it with a saline bottle, for some time. Then I ask the patient to stay prone. But now I see, turning, to make them go back to supine, which is right. My teaching was to make them lie prone for 2 hours, then only allow them to turn around. What is the current practice? Because the juniors who join me, they say turning back will give pressure and will stop bleeding because the weight will compress on the gauze dressing.
So that's what we do.
When turning back, there is no counter pressure on the anterior abdominal wall.
What is the practice?
The patient is prone with a small pillow under the tummy, then you are applying pressure on the other side.
Yeah, yes.
And that is more effective than turning the patient back very early.
We keep the patient
supine. Now that we have the ultrasound, we can also check for the bleeding immediately after the ultrasound.
We just keep the patient supine for 2 hours with that heavy pressure dressing that you mentioned, Bala. That's what we do. Because none of us will sit for like 20 or 2 hours and hold it in the prone position because we have other cases. And that's I did not realize that we can do it the other way. I was always taught supine.
Talking about the biopsy, I just want to pose another question. You want to prefer to do it in deep inspiration or deep expiration, full expiration? Opinions.
Sir, it depends on its relationship to the rib. If it is obviously, the rib is not disturbing, then I ask them to hold the breath, mid position. I don't insist on a deep breath.
Right.
So, Bala, see, I've done it in all 3 positions: deep inspiration, breath hold; deep expiration, expiration, breath hold; mid expiration, breath hold. So it depends at which point, because we are doing live. So at which point you'll get the best hit to the kidney without going through your ribs. So whichever way you get the best window, I think that's the best. I don't think there is anything like deep inspiration or expiration.
Yeah, I would agree with Hemant because you're looking at the lower pole and it doesn't matter how that pole comes. When you get it, you take that shot. You can have the patient breathe and the patient will start, tell them hold, they'll breathe. And we're still going through it. All of us have done it, even though we're not admitting. So you get that lower pole, you go for that.
Yeah.
Senguttuvan sir,
yes,
how many days post biopsy you applied this glue to stop that aneurysm, persistent aneurysm? How many days was this procedure done post biopsy?
Like, I'm sorry, I couldn't understand. Like, how many times is it, or how many days?
Days post biopsy was you tried and closed this persistent tract.
So as Dr. Adrian said, there are 2 many patients behind us.
How many days after they showed the patient to you to close that tract?
It is always immediate. I don't want to send the patient out of my radiology suite without blocking it. Like basically, I want to go on with the other patient, not having this.
Acute immediately after doing the procedure, you do that.
Yeah.
Okay.
So once a large hematoma has happened, targeting that would be very difficult. Then it has to be trans endovascular. So there again, 1.3 lakhs gone.
Right.
Okay, so that is more important because many times we see this, we'll be worried looking at the hematoma size which is enlarging, and we'll be threatened for the next 6 to 12 hours. We'll be in a difficult situation. So it is a useful thing what you did, what you said. I think we should all learn this, how to do this from you.
Dr. Pandian, let me
I
ask
don't know who is speaking like, but he has just spoken the heart out of most of the nephrologists. Do a biopsy and you just fear for your life for the next 24 to 48 hours.
Let me ask you all another question. What gauge, Dr. Pandian, what gauge needle are you using to do your biopsy? Gauge
18.
Huh?
18.
18. So, I've always done this 18 gauge, unfortunately. So we reviewed the literature on this and we found the chances of, I was using 18 because I thought, hey, the chance of bleeding is smaller because you're using a smaller gun diameter, so less bleeding. But we found that whenever I was doing that, I was hardly getting much gloms in my biopsy. And when we reviewed the literature, they found there is no difference whether you use a 16 gauge or an 18 gauge in terms of bleeding. And so I switched to a 16 gauge now. So I get a lot more gloms.
I'll answer that question, Dr.
I would agree with
you.
Again,
yeah, he will do a biopsy even with the 14 gauge needle as well. It's me who has made him do with 18 gauge, just because of my pursuit. But as so far for the last 250 biopsies, we have not really faced any shortage of glomes that we could not make a diagnosis, so we're not changing our practices. That's the reason. But I agree with you, there is no major difference in bleeding between 16 and 18.
As far as biopsy guns or whatever is concerned, like one patient, 3 cores were taken. This was my in my period in CMC. 3 cores were taken. 4 aneurysms formed in 2 days. Okay, so does the gun really play a role, or is it the kidney's basic nature? So can't expect 4 aneurysms in 3 biopsy cores. So I think kidney also plays a role.
Probably the CMD Senguttuvan.
Yeah.
No, and also not to forget, see, there is a difference between small perinephric hematoma versus an aneurysm. Those are 2 different situations.
Yeah.
Many a times a small perinephric hematoma does occur. I mean, we have seen it. We do a biopsy, it's there. We wait for 5-10 minutes. We repeat an ultrasound. It's not increasing in size, and that will remain as it is forever. So those are different situations than those who have major bleeding. I mean, page kidneys, one thing we had faced once when I did a single kidney transjugular biopsy. So that's another different situation. And AV fistula, which bleeds, almost to death, hemoglobin dropping, is a different situation. So we are mixing up all the situations for an intervention may not be appropriate. We need to choose the patient as to which one would cause a problem and needs an intervention versus those who can be observed on its own, maybe with tranexamic acid, pressure, etc. Complete bed rest.
You had asked Senguttuvan whether he does it in transplant kidney. Actually, the pictures he showed are all in transplant kidney only. Then Senguttuvan,
yes, sir.
Between in an ongoing bleeding, between attempting this transcutaneous, percutaneous blue injection and regular transrenal artery coiling or other methods, which should you prefer? Ongoing bleed, not a preemptive.
Ongoing bleed. See, when will we intervene transarterially because of the thing? It's going to be late, maybe 2 hours, 3 hours when you see if hemoglobin drop. So at that time, there will be no pseudoaneurysm for us to target by percutaneous method. So it will be intrarenal. So I don't want to go intrarenal. I want to be on the capsule. So in that case, so transarterial is for delayed, like profoundly hypotensive. I do an ultrasound. I don't see a pseudoaneurysm. I don't see an anechoic area. For example, like 2 days back, one patient, we did a biopsy. I can only say the kidneys are there. So such hard skin the patient had. So in that case, I don't expect me to see even a hematoma. I am unable to find an hematoma. So bad window, large hematoma, significant bleeding. Yes, we go for transcatheter, endovascular. If it is small, superficial, thin patient, rapidly hematoma is forming in front of us in the first few minutes. When that is a narrow window where we got, wherein we inject the glue at that time, and hopefully we avoid the bigger, we control the bleeding at that point itself. So it's more preemptive. I don't think it is going to be useful as a therapeutic method. And as I said, again, transplant kidney easy to compress. So we want to extrapolate this technique for the native kidneys. That is the ultimate aim.
I'm going to try this technique next time. I don't have glue in our IR suite, but I'm hearing this and I'm still apprehensive about 0.5, and we have such a long, Chiba needle. Sometimes we use 15 centimeters.
I'm using a lumbar puncture needle. That's just half the length of Chiba.
Well, the reason is, our patients are a little bigger.
And, yeah.
And so I try to use a longer needle. And I guess you can use same thing with your biopsy gun. Are you using a 16 centimeter or a 20 centimeter gun? And so some people have in our patients that fat at the back is a little large, and we struggle. And so even though you have a bleed, now you have to figure out how to get that needle back in. And you've lost the plane because you took out the probe, and now you're looking at it. Now you're saying get everything back in. So that's what I'm thinking, whether 0.5 is too less, or maybe we should go a little more on both sides.
Said 20 centimeters. I think I have not used more than 16. Any of us, I don't know. 16 centimeters, not more than 16 centimeters.
All right. So my only thing was whether to use more than 0.5, 0.7, maybe on either side of this anechoic area, because you don't know where you are exactly.
Exactly.
And it's hard to even see the needle when you use that thin lumbar puncture needle. You can't see the needle with the ultrasound sometimes.
LP needles are very bad as far as ultrasound visualization. So maybe a T1 needle with that smart tip, maybe that is a better option.
Okay.
Then Senguttuvan, Dr. Vail wants to know, have you followed these patients after the glue injection over time? What happens to the glue?
Yes.
It causes fibrosis.
It induces an inflammation for the first 1 week. That is the theory part of it. All of them are coming to us for follow-up, sir. They are good. No. Like I would have used for 3 patients, all are good.
No pain or no complaints whatsoever, sir. Like it's been stable. We checked the ultrasound as well once or twice. I mean, it's all good.
But again, Anki, there are situations. I mean, we always do under ultrasound guidance. There are many times when you see some bleeding in the muscular plane or in the pericapsular area, but we don't do anything and nothing happens. So how can you be sure this glue was helping? And but of course,
that's a right question. I'm not sure, sir. Because only thing is when you do a biopsy and apply a proper Doppler and see a jet coming out, you are literally forced to do something.
Actually,
I'm not sure.
Continuous ultrasound monitoring immediately, continuous, not even taking the probe out for a second. You can see the rapidity at which the hematoma forms. So that can give us a clue whether you should go and intervene or not. So this patient we tried just because of this platelet count, transplant kidney, fresh transplant kidney, couldn't apply much of compression also. Yeah, that is the reason we attributed.
And we have done some 4 or 5 plasma exchanges with a little deranged APTT as well. So we did not, there are so many things at stake. So we did not want to take a chance.
You mentioned about the rapidity of which hematoma forms. I happen to unfortunately have one like that. I just couldn't make out at what I was looking at. The kidney just disappeared. Within 2 minutes, kidney just disappeared. I didn't know what I was looking at. And the patient was complaining of so much pain. So I knew something bad had happened, and it turned out to be a big page kidney after that. So, it's nice that we talk about this, but sometimes reality is, it happens so fast. That opened my eyes as to how fast a hematoma can happen.
Then one last thing. Senguttuvan, did you mention that you used glue for catheter bleed also? I mean, the catheter tunnel bleeding.
We can use it, sir. We can use it.
So it doesn't damage the catheter?
Yeah, that is one thing that I don't know. I'm sorry. I mean, I thought neck incision, yes, we can definitely use. This, no, I have not tried.
Okay.
Potentially.
When you do the ultrasound, after you inject the glue, does the glue appear radio opaque or does it shadow?
The shadow.
The other situation where we have used this consistently, we used it for accessory veins, particularly after intervention. If we feel like there is a significant accessory vein which might compromise the flow to the main fistula, in those situations, what we do is normally cannulate the accessory vein, do the intervention through the vein, and we sort of sacrifice the vein at the end of the procedure by injecting glue through the same sheath or maybe through a smaller catheter. We have done it a handful of times and it helps all the time. Only thing you need to make sure is we have to close the mouth of the main fistula to make sure like it doesn't enter the fistula.
If you have an accessory vein, the flow will go sometimes away from the fistula somewhere else, right?
So let's say there is a accessory vein which can be accessed to manage your stenotic lesion. Let's say there's a juxtaanastomotic stenosis. You cannulate the accessory vein, you take care of the stenosis, and you want to close the accessory vein as well. You can put a stitch as well, but you have a sheath in the accessory vein. inject a bit of dye. Maybe you have to close the distal end of the accessory vein to make sure your glue doesn't get washed away, and it acts as once. The moment it comes in contact with the blood, it solidifies. So it's pretty easy.
So how do you close that accessory vein, Venki sir? Is it with the balloon or you manually compress?
Nothing. Manually. At the place where it joins them. Our only worry is it should not get into the main fistula trunk.
But can't the glue embolize, because the direction of the flow in the accessory vein will be capillary?
Yes, most of the time this accessory vein is not all that big. It is going to get embolized in the pulmonary circulation. Most of the time it is not. So that's not a concern.
0.5 ml is okay. And it will, by the time it reaches, it is going to polymerize. And second, the pressure at which we are going to inject and the pressure in which it is retrograde and this is antigrade. So we may not match it perfectly. So that is why we block the ostium, that junction where it joins the fistula. So if you apply with forceful pressure, it can go into the fistula, even though the blood flow is towards the sheath.
Oh, I now I understand what you're saying. You're saying put the sheath in the accessory vein.
Yeah.
Okay.
We don't touch the fistula. We don't want to touch the fistula at all for any access.
Right.
Can you repeat the commercial name of the glue?
Many things. Jessica, histacryl, endocryl.
Okay. Right. I think we had very interesting and newer things to discuss today. And I should thank our chairpersons, the guests, the faculty, and all those who attended today. And I think we can call it a day. Is there anything else anybody wants to add or mention?
Yeah, it was a very, very useful and very educative session, Bala.
Right.
Yeah.
Thank you. Thank you, Kashi sir, for spending so much time with us.
Thank you. It was a useful.
Thank you all. Thank you.
Thank you, sir. Thank you very much.
Thank you, everybody.
Bye, everybody.
Yeah.
Good night, everyone.
Good night,
Hemant.
Yeah, good night. Bye, Adrian.
So good morning, Adrian sir.
Bye, guys.
Hemant, answer my call. I would like to know more about the heparin bottle because I'll have to go to the hospital now.
Yeah.
I'll call you just now.
Yeah, sure. Yeah, bye.